Okay. Assalamu alaikum. My name is Dr. Mohammed Abul Khair, CEO of MCO. Dr. Suhail Rakun caught up in the emergency room at Rashid Hospital. So he will be joining us soon. But we want to start on time, and I would like to welcome to our seminar and webinar, Transforming MS from Paper to Practice, Dr. Dr. Tawfiq Al-Saadi, who is the Chief Medical Officer and Chair of Neurology at the American Center of Psychiatry and Neurology in Abu Dhabi. He's well-known in neurology in the Emirates and specifically in Abu Dhabi. Was the chairman of the department at SKMC for a long time. And here he will speak to us about when early is early. And we would like to start welcoming Dr. Tawfiq for his speech.
So let me start off by introducing a few concepts which I'm sure most of the audience are quite familiar with. As you know that MS is a neurodegenerative disease characterized by recurrent relapses. Some of the relapses that patient would have may result in complete recovery. Others may result in incomplete recovery, and others may result in some residual deficit. But regardless of the number of relapses, the ultimate feature of the disease, especially with several years since onset, will be accumulating disability. And that again is independent of the number of relapses. And that again shows the importance of early intervention before our patients would reach that final stage of accumulating disability. The issue with this disorder that, as I mentioned earlier, is characterized by recurrent relapses, that early on inflammation would be the hallmark of the disease. And as you can see in this slide, that can be manifested by acute inflammation causing some GAD-enhancing lesion. If it happens that you would order MRI early in the course of the disease. But most of the activities that you see with this disease will be in the subclinical levels. And in addition to that, and that's very importantly as well, that axonal loss tend to occur very early at the start of the disease and to continue to build up throughout the years of the course of the disease. And most importantly, that you will find, as you can see from this work by Dr. Trapp, that most of the axonal loss occurs within the first year after the onset of the disease. And that, again, that shows you the importance of early intervention, not only early, but probably aggressive intervention in order to prevent that significant axonal loss that will result over years of follow-up into diffuse atrophy. And as you can see from this slide on the right-hand side, that most of the axonal loss occur within the first 5 years, and the following years, the axonal loss tend to diminish, but it is an ongoing process. So you can easily distinguish two parts of the disease. The early part, which is characterized by the peripheral infiltration and inflammation, and the later part was a CNS compartmentalization and degenerative process characterized mainly by axonal loss. But you need to keep in mind that the inflammatory process is an ongoing process even at the later stages of the disease. It is very true that it's maximal in the early stages of the disease, but that process is ongoing and it continues throughout the course of the disease, but obviously tend to diminish in the later stages of disease, as I mentioned earlier, with the CNS compartmentalization component of the disease. The ultimate, obviously, point of that disease, that would result into diffuse atrophy. So it is an ongoing process characterized early on by acute inflammation with some axonal loss, but that continues throughout the course of the disease, resulting into diffuse atrophy. So obviously, part of the problem with MS that significant proportion of the disease occur under the surface, and some of the patients may have some clinical symptoms before they even know they probably started to have MS symptoms. And because obviously of the axonal damage that can occur before having any clinical signs or symptoms of the disease, and the damage may go unrecognized until probably it's too late to make any intervention that would restore the function of the damaged component or the damaged organ. And indeed, if you look at this work in patients with CIS before they even diagnosed with MS, and as compared to healthy control, you can find that patients with CIS are more likely, as you can see, about 57% of them, to have some cognitive impairment as compared to the healthy controls. And most of the deficit that you can encounter in patients when you do the psychometric testing would be the speed of information, processing, as well as attention. So that, again, to show you that even early on, before the MS was clinically diagnosed, there's an ongoing process that had resulted in some form of cognitive impairment before patients had even been formally diagnosed with MS. And as I mentioned earlier, it all has to depend on the functional capacity of the brain, because the brain maybe early on will be able to compensate for some of the early axonal loss. However, when it reaches a threshold that the brain may not be able to compensate, that at the stage when patients just start to manifest some signs or clinical signs of worsening MS. And again, that could be probably too late to intervene at that stage, because as the disease progresses, the neurological reserve would become obviously depleted, which may result in reduced ability of the brain to compensate, obviously have difficulty recovering from relapses, worsening of symptoms, and progression of disability. Giovanni had come up with a theory of asymmetrical neurodegeneration process based on his theory of that most of the involvement in patient with MS is length dependent, whereas you can see, for instance, the lower extremities are heavily involved because, again, it's a length dependent process according to his theory, though it is a random process. And because of that theory, that call to intervene at a stage before some of the organs that can be involved in that process would have irreversible damage, where intervention may not be at that stage quite adequate to restore that impaired function of that organ. So you can distinguish two parts of the disease, early part and later stage of the disease. And the main question that we face, would starting treatment early at the time of the diagnosis would prevent patients from reaching the progressive stage of the disease, or should we wait until we see clinical signs of progression at that stage? Would switching to a higher efficacy treatment will take us to the same route with the ultimate goal of preventing the worsening progression of the disease? Obviously, from looking at this cartoon, it clearly shows you that if you start early at the early stages of the disease, that would basically result in a better outcome as compared to patients who would start at a later stage of the disease, which may result obviously in some progression, and probably it would be too late to intervene. The question, do we have data to support that theory? Well, if you look at this work at patients with newly diagnosed MS, consists of 639 patients. These patients were started at different strength of immunomodulating treatment. Some of them had started on interferons, some of them had started on fingolimod, some of them had started on rituximab. And if you look at the risk of reaching irreversible ADAS score of 4, had definitely increased by 7.4% for each year of treatment delay. So patients who started on treatment, again, regardless of the treatment, being interferon, fingolimod, or rituximab, less than 1 year, are less likely to reach that stage of ADAS score of 4 as compared to patients who started on treatment between year 1 and 3, as compared to patients who, for instance, started on treatment after 3 years. So clearly starting on treatment early had resulted in delaying the progression of phase of the disease. Another work based on the Danish registry, looking at the same thing. They looked at patients who started on treatment less than 2 years as compared to patients who started on treatment between year 2 and 8 after obviously clinical onset. Same as we have seen with the previous study, patients were started on different immunomodulating agents. Some of them were in platform therapies, others were on escalating therapies with fingolimod or almutuzumab or rituximab. And the risk of reaching the ASA score of 6 was similar to what we have seen with the previous study, was increased by 42% in the group of late starter as compared to patients who started on treatment early, meaning less than 2 years after clinical onset. Well, we have demonstrated so far that starting early treatment, being on interferon, being on platform therapy, or on medium strength immunomodulating agents, or on higher strength immunomodulating agents, would definitely delay the progression of the disease. But the big question that we may have in mind, would it make a difference if you start your patients on a platform therapy as compared to your bigger gun with a high efficacy immunomodulating agent? Would that make a difference? Well, some of the studies would address that point. This is the data looking at plotting all the studies that we have so far on patients with CIS and the likelihood of these patients converting to clinical definite MS. And as you can see from this example, that patients who started on cladribine, for instance, are less likely to convert to clinically definite MS as compared to other platform therapies. Obviously, with all the drawbacks, we're doing these meta-analysis because, as you know, the differences in the design of the trials, the inclusion criteria, etc. But it does at least give you a signal that starting on cladribine, for instance, would reduce that risk of patients converting to clinically definite MS as compared to patients on other platform therapies. Again, going back to the Danish registry, what they did in this study, they matched 220 patients started on some of the, we call it medium strength or platform therapy, let it be interferon, glatiramer acetates, or teriflunomide, or DMF, as compared to patients who started on fingolimod, natalizumab, or rituximab, or OFTAB. And if you can see here that the likelihood of patients reaching the HS score worsening was much less in patients who started on the high efficacy immunomodulating agents, one of these drugs that I mentioned earlier, as compared to patients who started on one of the medium efficacy immunomodulating agents. Obviously, some of them were platform therapies. In addition, the probability of patients having a first on relapse was much less in patients with the highly efficacy therapy as compared to patients with the medium efficacy therapy. Another study looking at MS space, where they again compared high efficacy therapy, fingolimod, natalizumab, as compared to the platform therapy, interferon, glatiramer acetate, and the look of the cumulative risk of conversion to secondary progressive MS following their first treatment with one of these two lines of treatment. Again, the study came in favor of the high efficacy therapy, where the less likely patient would go on to the secondary progressive phase of the disease as compared to patients who started on one of the platform therapies. Similarly, the data on almutuzumab had confirmed the same thing. The likelihood of disease progression or disability progression had come much later if patients started on this treatment as compared to the interferon therapies. Another study based on real-world evidence looking at patients who started early on with a high efficacy therapy as compared to patients who were switcher, meaning they would start on the high efficacy therapy after they failed, and then they were escalated to the high efficacy therapy. And the secondary outcome of that study was sustained disability. And as you can see very clearly in the slide, that likelihood of patients reaching that stage of sustained disability was much earlier in the switcher or in patients who followed the escalation approach as compared to patients with the early intensive treatment, meaning that patients who started on early intensive treatment were less likely to reach that stage of sustained disability as compared to patients who started on that treatment but later on in the course of the disease. This is the data on ocrelizumab, and we will get to that later on. as you know, early on with the study of eculizumab, which we'll get in more detail later on, where patients were randomized to either eculizumab versus interferon, and then they went into the extension phase of the disease. For patients who continued on the drug early on, and they continued on the drug throughout the long-term phase of the disease, the likelihood of them going into the progressive phase of the disease were much less as compared to patients who were initially on interferon, and then they were switched back to eculizumab after they entered the extension phase of the disease, meaning those patients were less likely to catch up as compared to the patients who early on started and continued on eculizumab from the start, from the onset. Now, obviously, our understanding of MS had evolved throughout the years. And now, especially after the recent McDonald criteria, we became more equipped to make an early and accurate diagnosis of MS as compared to the old days. So now we can make an early diagnosis of MS based on the modified criteria, which I'm not going to go in detail with. And because of that, the ECTRIMS and the AAN had come up with a very strong statement advocating early treatment, whether in patient with confirmed MS, early MS, or when patient in the CIS stage. In both of these examples, they called for an early and early on treatment with patients with either CIS or early signs of relapsing remitting multiple sclerosis. Same thing, the MS Brain Health had come up with a very strong statement advocating early and aggressive treatment for patients with MS because time is brain. And this is a very important concept that you need to bear in mind when you deal with patients with MS. Time is brain. It's very important to intervene early on at the time where brain is capable of restoring its capacity as compared to the later stage of the disease where the brain is probably depleted and may not be able to compensate for some of the lost functions. And obviously, as you can see from the slide, there are many reasons people may not be able to get to early treatment, being lack of access, difficulty in making the diagnosis, is it related to the cultural or educational issues? But all of these issues had to be addressed at multiple levels in order for allowing our patients to have the access to an early as well as right treatment in order to prevent the accumulated disability of the disease. In addition to that, you need to keep in mind whether we are dealing with patients with a relapsing remitting form of the disease or we're dealing with patients with primary progressive disease. And this is the two studies, the pooled data from the OPERA trial, as well as the data from ORTARIO trial, which we'll get to later on in patients with primary progressive disease. Starting on the treatment early on would definitely reduce risk of progression in both of these forms of the disease, being in the relapsing remitting form of the disease or in the progressive form of the disease. Both of them can have an effect on preventing the progressive phase or reaching the progressive phase of the disease. Obviously, our treatment goals had somewhat evolved over the years. Our obviously current treatment is to reduce disease activity by improving symptoms of relapses, reducing disease activity, as well as reducing the accumulation of disability. But more importantly, probably, is looking at the emerging treatment options, which is to prevent the development of relapses, reduction disease activity, and hoping to stop that disease progression. And obviously our aim for NEDA, which is no evidence of disease activity, and more recently we start to apply a concept of no evidence of progression or active disease, or NEPAD. B cells, as you know, are quite important in the pathogenesis of MS. As compared to the control, for instance, we know that B cells are quite prominent in the meninges as well as in the MS active lesions, regardless of lesion being active or in slowly expanding lesions, but definitely B cells are quite important in the pathogenesis of MS disease. Now, quickly, I'm just going to summarize to you the data specifically on the long-term extension data on OPERA 1 and OPERA 2, because this is an important studies to look at. As you know, the OPERA 1 and 2 looked at patients who are randomized to either interferon or eculizumab, and then after a screening phase of 4 weeks, they went into the extension phase up to 6 years. And as you can see here, that patients who started on eculizumab early on, they continued on that throughout the years of follow-up. Their obviously risk of having further relapses is much less throughout the years of follow-up as compared to patients who started on interferon and then they're switched later on to ocrelizumab. Obviously, these patients, when they made the switch, there was still a significant reduction in the annualized relapsing rate, but not to the same extent as we have seen in patients who started on ocrelizumab and they continued throughout the years of follow-up. And this is looking at this study, looking at the 24-week confirmed EDSS disability progression. As I mentioned earlier, that patients who started on ocrelizumab and they continued throughout the years of follow-up in the extension phase are less likely to reach that 24-week disability progression as compared to patients who started on interferon and then they were switched to ocrelizumab and they continued on the long-term extension phase of the disease. Similarly, if you look at the cohort of patients whom we're looking at the change in EDSS score from baseline up to 4 years of follow-up in both of these trials, again, patients who started on the drug early on, ocrelizumab early on, as compared to the switcher, they're less likely to reach that EDSS progression as compared to patients who were a switcher from interferon to ocrelizumab at a later stage. Similarly, now what they try to do in the follow-up study, they try to look at 48-week confirmed EDSS disability progression, because obviously if you look at the 24 weeks may not be adequate to assess the long-term effect of this medication over long-term of follow-up. So they want to assess longer term of follow-up on these patients to make sure that this drug continue beyond that traditional 12-24-week assessment. And that had been observed in that study looking at 48-week confirmed EDSS disability progression. Similar to what we have seen with the 24-week confirmed EDSS disease progression. Same thing, exact same thing. Patients who started ocrelizumab early on, they have a less risk of going into the 48 weeks confirmed disability as compared to the switchers, meaning they started on interferon and then they were switched to ocrelizumab. Less risk, obviously, of reaching that stage on the ongoing treatment with ocrelizumab as compared to the switcher to this medication. Also, in addition to that, if you look looking at the clinical disease improvement, similarly, patients who started on ocrelizumab and continued on that for long-term follow-up of the disease, more likely to reach that stage of clinical disease improvement as compared to the switcher from interferon to the ocrelizumab. That would reflect as well in terms of improvement in the total brain volume, where patients who start ocrelizumab continue throughout the years of the follow-up, more likely to preserve their brain as compared to patients who start on interferon, then were switched later on to ocrelizumab. So obviously, in both on the double-blinded phase of the trial, as well as in the long-term data, we have seen, for instance, in the double-blinded phase of the trial, that the drug had significantly reduced the relapsing rate as compared to placebo arm, obviously. The ocrelizumab had significantly reduced the EDSS progression. In addition, it definitely reduces the burden of the lesions and increases the chance of patient reaching the NIDA stage as compared to the interferon arm. When we look at the extension phase of the trials, clearly that the initial reduction in the annualized relapsing rate that we have seen with the ocrelizumab had been maintained in patients who continued on the drug. For the switcher from interferon to ocrelizumab, they obviously have noticed some subsequent and some robust reduction in annualized relapsing rate, but they did not yet had reached or catch up with the reduction that we have seen with the ocrelizumab arm. Patients, however, who started on ocrelizumab as compared to the patients who were a switcher from interferon had a significantly greater disability benefit as compared to the switchers. And obviously, the earlier treatment with ocrelizumab had lower the brain tissue loss with time as compared to patients who were on interferon and then they were switched to ocrelizumab. And we have also demonstrated that the early needle can be easily reached with ocrelizumab treatment as compared and maintained as well as compared to patients who were on the interferon and then they were switched to ocrelizumab at a later stage when the patient entered the long-term phase of the disease. Now, what about patients with primary progressive disease? And that will be looking at the long-term extension data with ORTARIO study. As you know, that patients after the randomization, they go on to the extension phase of the disease. And similar what we have seen with the initial trials with the OPERA 1 and 2, same exact findings basically. The time of onset to disease progression 48 weeks after the randomized phase of the trial was much in favor of patients who started ocrelizumab as compared to patients who were on placebo, and then they were switched to ocrelizumab when the patient had entered the long-term extension phase of the trial. Looking again at the 24-week confirmed EDSS disability, same exact finding as we have seen with the patients with the relapsing remitting phase of the disease with the OPERA 1 and 2. Patients on ocrelizumab and maintained on ocrelizumab throughout the years of follow-up were less likely to reach that 24-week of confirmed disability as compared to patients who were on interferon and then were on placebo and then they were switched to the ocrelizumab arm at the long-term extension phase. Even looking at the time to onset of EDSS-7, much in favor of the ocrelizumab arm as compared to the placebo arm, and then they're switched later on to the ocrelizumab arm. So all in all, clearly we have shown that ocrelizumab, early treatment of ocrelizumab had resulted in significant preservation of the brain volume, and that can be seen in this trial, that the brain volume loss is less likely in patients who start on the treatment and continued throughout the years of follow-up as compared to patients who started on placebo and then they were switched at a later stage to the active medication. Similarly, the burden of T2 lesions are much less in patients who started on the drug early on and maintained as compared to placebo arm treatment and converted later on to the drug as well. Similarly, what we have seen with the OPERA 1 and 2 trial, we have seen benefit of this medication in both in the double-blinded phase of the trial as well as in the extension phase of the trial, where in the double-blinded phase of the trial, the drug had significantly slowed the EDSS progression. It's definitely preserved the upper limb function as compared to the placebo arm, and it definitely had reduced the burden of the lesions as well as the brain volume loss as compared to the placebo arm. Similarly, when we look at the extension phase data, the earlier treatment with the drug had provided long-term disability benefit as compared to the delayed treatment. The earlier treatment with the drug had delayed time to fundamental clinical milestones, such as loss of upper motor function and obviously time to wheelchair bound as compared to the placebo arm, and then they switched later to the medication. And the earlier drug had provided long-term reduction in the brain volume as well as the total T2 burden as compared to patients who start on the treatment but at a later stage of the treatment process. So I just want to sum it up that in patients with relapsing remitting MS disease, patients who started on ocrelizumab as compared to the patients who started on interferon had reduced relapse rate and reduced level of disability, which can be maintained and can be observed throughout the years of follow-up. The patients who were switched from interferon then to ocrelizumab, there was significant reduction in the annualized relapsing rate. In patients who had a diagnosis of primary progressive MS, patients who started on ocrelizumab as compared to the placebo arm had lower rates of clinical disease progression, which had been maintained throughout the years of follow-up. And the earlier treatment with the ocrelizumab had provided long-term disability benefit as compared to patients who started on the medication but at a later stage of the disease. And all these trials, OPERA 1, OPERA 2, as well as the extension phase of the ORTARIO, all had provided us with a very important information that will guide us into treatment with this medication and would be a big advocate of the early and aggressive treatment with a highly effective medication such as eculizumab. And obviously that had been supported with several real-world evidence data that would support the earlier use of the right treatment for patient in order to prevent the reaching the progressive phase of the disease. With that, I would end, and thank you very much for your attention and for the invitation to speak at this meeting.
Thank you, Dr. Tawfiq, for excellent presentation on ocrelizumab and on the disease-modifying therapy versus the platform therapies, and showing the efficacy in early treatment for both relapse MS versus and primary progressive MS. So we'll open it now for question and answer. And one of the question from Dr. Rabha saying, what is the safety of ocrelizumab during the pandemic of COVID-19?
I think this will be addressed in the two case presentation that will be presented by Dr. Caesar, so we can defer that discussion at that stage because that will be addressed in his case discussions.
Okay. Second question, Dr. Nawal saying, how much time does it generally take to have accumulating big disability in case of MS?
It really varies from patient to patients and depends on the underlying pathophysiology. And some patients may take several years, 10 years plus, and others may take even less than this. So it really is dependent, it's patient dependent, based on the underlying pathophysiology of the disease. Regardless, it's a call to have an early intervention before we reach that stage. And obviously in some patients whom we see an early sign that suggests we are dealing with an aggressive form of the disease, for those patients specifically, we probably have to be more careful, and we should be more advocate and a stronger advocate for an early as well as an aggressive treatment before patients reaches the irreversible stage of the disease.
Okay. We have one of the attendees. She said, I'm a dentist, MS patient diagnosed in 2002, started betaferon in 2006, escalating treatment to Mavinaclad the following week. And she said, is your advice to start aggressive treatment from the start, irrespective of whether it is a minor form of MS or not?
Well, again, this is what we're trying to say. I mean, every patient is different. I mean, I don't know about this particular case. I personally am in favor to treat patients early on, regardless if you're going to go with the platform therapy or with the medium or high strength immunomodulating agent. I strongly believe in the stratified management of patients with MS, meaning that for patients whom I believe there are signs suggest that more likely we are dealing with a mild form of MS, I'm more inclined to treat them with the platform therapies as compared to patients, for instance, where I see some sign to suggest that probably we are dealing with some form of aggressive form of the disease, or more likely patient would progress over time. For those patients, again, I'm more in favor of hit them with the big gun right from the beginning.
Okay.
Because I still believe actually there are some forms of MS that can be quite mild and they can be benign. I mean obviously the jury is out, and some may disagree with me about that concept, but I believe the concept of benign MS do exist, and there are some subpopulation of patients with MS that they do have the mild form of MS. For those, I probably would be more cautious before I would consider hitting them with the medium or high strength immunomodulating agents.
Okay. A question from Noor Ali. She's saying, how to manage depression when on ocrelizumab?
Well, depression, as you know, is quite common in patients with MS, and the literature is full of studies that have clearly shown that patients with MS are more likely to have comorbid depression as compared to general population. So obviously, if your patient had comorbid depression, it's not because of the drug, it's just because of the MS itself. Ocrelizumab would not cause depression, but patients with MS in general are most likely to have comorbid depression. And again, the treatment would be dependent on the severity of depression and how familiar and competent and how familiar you are with the various treatment modalities in patients with depression. If you are quite familiar with the management of depression, then I would start them with one of the SSRIs. They're quite effective, easy to manage in patients with comorbid depression. SNRIs as well can be also effective. In addition to that, they will confer the advantage of having their protective properties in terms of managing neuropathic pain, which, as you know, is quite common in patients with MS. But basically I would start them with simply with SSRIs first.
Okay. Dr. Gopinath, she's saying one of my patients is not willing to have any sort of disease-modifying therapy. She prefer to be on steroid. How to explain the safety concern to the patient?
Well, it's not the safety concern. Obviously, it's going to be the issue of the disease progression. And you probably have to share with her some of the data on the natural course of the disease in patients who are undertreated or untreated, because as you know that ultimately the patient may reach the stage of irreversible damage if they are undertreated or they are untreated as compared to patients who are treated early on. So I would suggest, it depends obviously on the level of education of that patient, I would share with her some of the data, either the natural course of the disease in patients who were not treated at all or in patients who were undertreated. And by the way, this is not the first time I've heard that patients refusing treatment and they elect to go on whether monthly or quarterly, for instance, treatment with IV methylprednisolone. I've seen it, and I know some people are doing it, but it's our obligation as a healthcare provider to advocate our patients about this wrong practice and to suggest to them to go on to right treatment in order to prevent that reaching the stage of unfortunate disability.
Okay. Last question before we move to Dr. Caesar is there any guidelines when to start high efficacy drugs or the disease-modifying drugs?
There are several guidelines that had been put together by the Menactrums, as well as which had been recently updated, and I'll be happy to share with the group the recent guidelines that would basically summarizing in a stratified manner which drug you would choose based on the level of the disease stage. Platform therapy as compared to escalation therapy, or to start some of these patients early on with a high efficacy treatment. And that has been well outlined and well addressed in the recent Menactrums guidelines.
Okay, so Dr. Tawfiq can share this guidelines with the group.
Yes.
Okay, thank you very much, Dr. Tawfiq, for a very informative session. And we will move now to Dr. Caesar Zakka, who is a consultant neurologist at Al-Zahra Hospital in Dubai. He is an American board-certified neurologist and has been practicing neurology for the past 20 years. And he will present 2 cases of Ocrevus from paper to practice. So, Dr. Caesar, the floor is yours.
Good evening. Thank you, everybody. I'll try to share my screen. Okay. So I don't have maybe as high voice as Dr. Tawfiq. I hope you can bear with me. So basically, I'll start with case 1. This is a naive patient, 35 years old, Sudanese gentleman. He came first time on the 25th of August, 2020, because of numbness was felt on the right side of the face and the whole tongue for the last 10 days. It was coming on and off with minor paresthesia in the fingertips and toe tips, which started after that. Test was okay, no other complaints, no significant past medical history, has a history of hemorrhoidectomy. He smokes 5 cigarettes per day, non-drinker, no other illicit drugs. So the symptoms were quite mild and not typical of the usual MS attacks we see. However, the physical exam showed lungs, heart exam was normal, no carotid bruise. Lhermitte sign was slightly positive, mental status normal, and he showed an obvious vertical nystagmus, skew deviation, in addition to right gaze horizontal nystagmus, no afferent pupillary defect or internuclear ophthalmoplegia. There was a decrease in touch and pinprick on the right side of the face, and there was no tongue deviation. There was, in addition, a mild right drift. Otherwise, no major motor or sensory deficits were seen in the extremities. There were no cerebellar signs, no pyramidal signs. Romberg was negative. Gait and coordination were normal as well, and deep tendon reflexes were normal and symmetrical. I ordered an MRI on this gentleman, and the MRI showed, I was actually amazed to see the number of lesions he has. So he had infratentorial lesion seen in the pons, in the medulla. There were tumefactive lesions seen in the right temporal lobe and in other areas as well, multiple lesions, some of them taking cystic pattern. There were multiple callosal lesions, juxtacortical and periventricular lesions. This is the same pontine lesion we saw earlier. MRI with contrast showed some burr holes on the T1 in addition to partially enhancing lesions. As we can see, some of the lesions were partially enhancing and some of them were not. So this patient met the criteria for dissemination in time and space. Again, the same lesions we can see. Now, because of the somewhat atypical presentation and because of the multiple cranial nerve deficits, we saw, in addition to multiple sclerosis, I was suspecting neurosarcoidosis as another less likely diagnosis. Chest X-ray was done, was normal. VEP was normal. Blood test, including thyroid function test, NMO antibodies, ESR, S levels were all normal. CSF showed 20 WBC, 80% of them were lymphocytes, 2 unmatched oligoclonal bands, and increased IgG. The patient received 3 days of Solu-Medrol, 1 gram daily. The numbness in the tongue and face were better, but he was experiencing some fatigue since the beginning of the symptoms more than his usual. Disease-modifying treatments were discussed thoroughly with all the pros and cons with him and his fiancée, who seemed to be even more interested in reading about all the different disease-modifying treatments and having the conversation about that. So in this gentleman, there were multiple concerns. First of all, that there was an aggressive nature of the lesions radiologically, even though clinically it was a mild presentation. There were other risk factors, being male, age 37, enhancing lesions, infratentorial lesions. Some studies may speak about also the African, because usually we are sort of in the beginning, when we spoke about MS first, always the Caucasian were apparently more predisposed. So with African being having the disease and with this amount of lesions, that can also have a higher risk. So escalation treatment seemed to be quite necessary to use rather than going with the platform therapies. Between the escalation treatments themselves, Ocrevus seemed to be a good option, especially during the COVID-19 situation. And in addition, the mild clinical scenario relatively, because as we know, we have also between the escalation treatment, the Lemtrada, the Cladribine, etc. But sometimes with this milder sort of clinical presentation, with the discussion with the patient, we felt that we may go with Ocrevus rather than with Lemtrada, and especially with the COVID-19 situation in the beginning, there was some concern, especially about the Lemtrada and also about Cladribine earlier on. So he received the first dose of Ocrevus in the beginning of October. Second dose was in the mid-October. As a follow-up, the sensory symptoms have decreased markedly. He still feels more fatigue than usual, in addition to some insomnia. He was placed on amantadine 100 milligram daily, in addition to increased caffeine intake, and is also on vitamin D and PRN Midocalm for muscle pain, which he experienced sometimes. Now we move to a case which is totally different from the first one, which is a switch on treatment from another to Ocrevus. So this is a 51 years old Jordanian American woman. She had her first attack 7 years ago with paraparesis and gait deficits involving the lower extremities and more the left lower extremity. She had another attack causing increased weakness in the lower extremities and mild left upper extremity weakness in the same year. She had a positive MRI and CSF spine. She had positive MRI of the brain and spine in addition to positive CSF and was diagnosed with relapsing remitting MS. She was started at that time on Copaxone about 6 years ago and was continued for 2 years. Later on, it was stopped because of injection site reactions, pain and swelling, in addition to feeling weaker for about 24 hours after the injection. However, her gait had improved after the treatment, and she did not experience further attacks. So at that time, because of the injection site reactions and because of the other symptoms she was experiencing, she decided to stop treatment for a couple of years. Till she got another attack 2 years later, causing her more weakness in the lower extremities and also mild weakness in the left upper extremity. So there seemed to be, in her case, some reactivation of maybe the same lesions. As was mentioned yesterday in another MS lecture. At that time, she received autologous stem cells from her fat cells in San Diego in 2018. She was using a cane at that time to go outside, but she can walk without a cane inside the house. She was put on Fampira 10 milligram twice a day and prednisolone 20 milligram every day when she came to see me in February 2020. She came to the ER on the 13th of February 2020 because of 1 month feeling increase in weakness in the left side with severe pain on the same side. She ranked it in a laughing way as 15/10, but she seemed to be quite in a pain. She received 500 milligrams Solumedrol in the ER, after which she felt somewhat better. She came to the outpatient clinic next day on the 14th. No other past medical history, no surgical history, and family history was unremarkable. She had normal general physical exam. Mental status was normal. Pupils were equally reactive. There was no partial afferent pupillary defect, no internuclear ophthalmoplegia. There was a horizontal nystagmus and up-gaze vertical nystagmus. Fundoscopic exam was normal. Other cranial nerve exam was normal. Bilateral drift is seen with the left more pronounced. Strength was 5- out of 5 in the right upper extremity, 4 out of 5 in the left upper and in the right lower, and 2 to 3 out of 5 in the left lower extremities. She came in a wheelchair, is able to use a cane, but with major difficulty, may be able to walk only less than 20 steps with a cane. There was increased tone in the left lower extremity, a decreased proprioception and vibration in the lower extremities and more so in the left. Lermite was negative. Babinski sign was positive in the left. Deep tendon reflexes 3 out of 5. She had a spastic gait on the left side. No cerebellar signs. EDSS was quite high, 6 to 6.5 at that time. She brought her MRI, which was done 1 year ago, and it showed multiple supratentorial, periventricular plus juxtacortical lesions, in addition to 1 infratentorial lesions and 2 cervical spinal lesions. She received 1 gram of Solumedrol for 3 days, followed by tapered oral dose. Osteocare, vitamin D, omeprazole were given. Routine labs were done. MRI was ordered without and with contrast. She improved markedly on the Solumedrol from EDSS 6.5 to 5. Options were discussed about the different disease-modifying treatment, and with her degree of disability and having tried first-line treatment or platform treatment, it was felt that escalation is definitely recommended, keeping in mind that she may be having secondary progressive course. However, she was voluntarily locked down due to COVID-19, and she was quite determined about not to do any further investigation and to have the treatment at this time because of fear of the COVID-19, especially in the early outbreak. She did the MRI in June 2020 and she was followed in July. Her MRI showed extremely heavy load, and there was actually increase in the number of lesions in the brain and cervical spine. She did not have, however, a clinical attack during the past 4 months. However, her EDSS again increased and became worse in the range of 5.5. It seems that there was some progressive component. And this is her MRI, which shows juxtaventricular lesions and periventricular lesions. Again, multiple subcortical lesions. We can see also infratentorial lesions, especially in the cerebellar peduncles and cerebellar hemispheres. Callosal lesions, subcortical, juxtacortical lesions. And we can see about 3 to 4 lesions in the cervical and upper thoracic spine. So the patient seemed to have an active secondary progressive MS. Why we are saying that? Because she definitely had attacks previously. However, the last attack that she came in February 2020 seemed to be of insidious progression. In addition, that after she got the Solumedrol in the last 4 months, also she seemed to progress in her EDSS, even though she didn't have a typical attack. So frankly, it was felt that at that time we can categorize her as secondary progressive MS, and especially active secondary progressive MS. Different disease-modifying treatments were discussed. She was given time to read also about the different medications. She felt more after also having this long discussion with her. She felt more towards the Ocrevus. Ocrevus, as we know, has been approved by the US FDA for the treatment of primary progressive MS, as Dr. Tawfiq mentioned now also, and as well as relapsing forms of multiple sclerosis, which include clinically isolated, relapsing remitting, and active secondary progressive MS. Ocrevus continues to be the most prescribed modifying treatment in inflammatory disease with active secondary progressive among US neurologists, even though Mayzent and Mavenclad were approved, as per some studies that were done in the US going over what is most used by different neurologists in the US, and it was felt that Ocrevus still is more used than Mayzent and Mavenclad for this indication. So Ocrevus was given in the beginning of October and mid-October. On follow-up in mid-November, she was feeling well, no complaints. Her EDSS has improved to 5 again. A blood count was within normal limits. I'm just mentioning the last slide about the autologous hematopoietic stem cell transplants. There is a current consensus supporting the use if we are dealing with relapsing remitting MS patients who are younger than 45 years old, able to ambulate independently, have illness duration of less than 10 years, and at least have 2 clinical relapses in the previous year, despite the use of other disease-modifying treatments with MRI evidence of concurrent disease activity. If the patient has a higher degree of disability or occasionally has a progressive course, it could be considered, but we have to keep in mind that it should, in this case, we should make sure that there is more MRI activity and that we are using it in a big center, specialized centers with interest in hematopoietic stem cell transplants. And thank you.
Thank you, Dr. Caesar, for your presentation on the two cases. And one of the questions saying that there are now many different disease-modifying therapy in the market, oral and injectable. How do you make your decision of what to start the patient on?
Very nice question. Definitely, we face this question on daily basis. It's not always easy to decide. We have to take different points. I mean, first of all, definitely, again, like what Dr. Tawfiq mentioned before, if we are dealing with very mild kind of MS, maybe we should go with the platform treatments. And we take into consideration the situation of the patient. If the patient, again, is a female, is expecting to get pregnant soon, so that all that can affect our decision which disease-modifying treatment we should use. Now, if we are dealing with more aggressive disease, such as I mentioned, the first patient, for example, we are dealing here with a patient who had multiple lesions, especially in the spinal cord. This is one of also the criteria for having a sort of high-risk patient. In addition to that, he had multiple lesions. This is his first presentation, and on physical examination, he had multiple, even though minor, but multiple deficits. So here we need to go into an escalation treatment. Now, between the escalation treatments, we need to take into consideration definitely the other maybe comorbid, if there are comorbidities going on. First of all, sometimes the patient preference, we need to know about the job of the patient, how easy for this patient to take this treatment, because as we know, now we have injectable medication that if the patient is traveling too much, we need to take that into consideration. Some patients also with their type of life they are leading, they may not prefer to take medications on daily basis. So they may prefer to take the medications that can be taken twice a year or once a year, etc. So that's also another consideration. So I can say, depending on the severity of disease, depending on the comorbidities, and depending on the patient preference, we can go with different disease-modifying treatments.
Okay. Eculizumab shown to slow the progression of the disease of MS. Can it stop relapses?
Can it stop relapses? I mean, it's definitely indicated for relapsing remitting MS, and by the studies, definitely it showed a major decrease in the number of attacks. And I cannot say that definitely for all patients it will stop all the attacks, but at least it will decrease the attacks in most of the patients. Yes.
Because, MS drugs are either moderately effective or more effective or highly effective if they reduce relapses by 2/3 versus 1/3 versus half of the. So you would say that it is highly effective?
Exactly, yes. It's considered between one of the highly effective treatments in comparison definitely to the platform therapies.
Okay. Now, a question here, this patient received the stem cell therapy. Would you say stem cell therapy now? Is it in the guideline? Is it advocated? And if it is, at what stage? And were the patient disappointed that she still had relapse even though she had stem cell therapy?
Okay, now, frankly, if the patient is in a very specialized center and meeting the criteria I mentioned before, we can go with that. But again, we need to keep in mind that if the patient is failing the other disease modifying treatments, frankly, if I was her physician back in US, I may not go to stem cell as a second choice. Definitely, I don't agree with going into the stem cell as a second choice. I don't know the details. I think the patient at that time was refusing the other disease modifying treatment, and the physician had discussion with her. This is at least what I remember what she told me. She was not into much after her experience with the Copaxone. She was not much into other disease modifying treatment. So after maybe long discussion and being in a highly specialized center and maybe being in a trial again, she decided to go into the stem cell therapy.
I see. Okay. One attendee is asking, why did you choose Ocrevus in each case, the naive and early switch?
Okay. Now, for the naive patient, again, I choose the Ocrevus, first of all, because it seemed to be an aggressive nature of the disease, at least radiologically again. And this is, again, the first attack with having all these lesions seemed to be an aggressive disease. So I had to start with I had to start with an escalation treatment, definitely not with a platform. But again, because there was in the beginning of the COVID-19 outbreak, maybe many of us know that in the beginning there was concern about all the DMTs. Later on, many DMTs were seen as safe, and few, such as cladribine and Lemtrada, were felt to be a little bit that they should be delayed. And later on, cladribine again turned out to be safe, and later on also the concern about Lemtrada decreased quite a bit. So at that time, Ocrevus, between all these, let's say, escalation treatments, seemed to be at least safer than the others because it affects mainly, again, the B cells. It doesn't affect B and T cells as, for example, Lemtrada. Now, for the second case, why did I choose Ocrevus? We may have chosen another one, frankly, but after long discussion, the patient also felt more towards the Ocrevus than any of the other escalation treatments, after knowing especially the side effects of each of the other medications. So she felt quite comfortable with the Ocrevus more than the other treatments.
Okay. We have a question. Aside from MS medication, what supplement is given to support the patients?
In addition to MS, now if we are definitely speaking especially during the COVID outbreak, now again, vitamin C, vitamin D, maybe zinc are recommended. Now, if you are speaking outside the outbreak, again, vitamin D, as we know, is very important to, there are a lot of studies that showed that people who have low vitamin D may be more predisposed to MS. So definitely checking vitamin D is important, and giving it as a supplement in people who have low, even with minor doses in people who have normal vitamin D, it could be a good reason for that. In addition, we can use just the normal antioxidants that anybody can use, but we emphasize that. Exercise also is important for MS patients. Having a good sleep, trying to improve their immunity by getting their good supplements, again, can be very important.
Okay. Question said, what maximum age, or what is the maximum age that MS can start on?
What maximum age now? There are, as we know, usually MS is more a disease in the third and fourth decade of life. But again, as we know, there are pediatric MS that we can see even in the first decade and second decade. And there are cases of MS that we can see in the fifth decade. So usually, still we can see it till age 45 or 47 or 48. After that and after menopause, it's very unlikely. And if we see any case of MS, we need to investigate other possibilities because it's very unheard of.
Okay. Question, for how long do patients need to take their treatment? And can they take a drug holiday for their treatment?
Now, definitely depending on what disease modifying treatment they are using, because as we know now, some of the newer escalation treatments we can use only for a few years, such as Lemtrada, for example. We can use only for 2 years. Now, for Ocrevus, usually it is for I think 192 weeks, which we are speaking mainly about 4.5 years. The usual treatment it is used. Again, but for most of the other treatments, we are talking about long life treatment for life. I mean, basically, especially if we are talking about the platform treatments.
And this question for Dr. Tawfiq: what is the possible reason of MS in pediatric cases?
I think he's muted.
Okay.
I think Dr. Tawfiq is muted, maybe.
Oh, you can answer that if you.
Oh, I'm sorry. Again, what's the question?
What is the possible reason for MS in pediatric patients?
I mean, what are the risk factors? Let's put it this way.
Risk factor, or why do children get MS?
Why do children now? Now, definitely in pediatric cases, genetic predisposition can play a big role. Sometimes, again, MS, supposed some viruses can predispose the patient to MS. Most of the time, we don't know. Frankly, most of the time, we don't know, but there are definitely genetic and viral predisposition to the disease.
Okay. Question: how do we manage patient who has MS and other comorbidities? High blood pressure, seizure, chronic diseases.
Exactly. Now, most of the medication usually do not cause major problem in those general concerns. I mean, definitely sometimes we can see some increase in hypertension after some disease modifying treatments, even including Ocrevus, but this is very rare. It was reported, but nobody knows if it is exactly due to the Ocrevus or it is just by matter of time. In general, we treat the other comorbidities like we treat them if we don't have MS. So basically, we need to treat the hypertension, we need to treat the asthma, we need to treat the thyroid disease. Some disease-modifying treatments, for example, Lemtrada, can cause in the third year or after thyroid disease. So in this case, we need to deal with that depending on the scenario, I mean, basically. But again, we can't treat them like the patient without MS, basically.
Okay. Can you tell us why did you choose Ocrevus in this patient?
Which patient, the first or the?
First one.
The first one. Again, as I answered this question, I used Ocrevus because there was an aggressive nature of the disease again, and at the same time because of the clinical mild scenario in general, I didn't want to go into Lemtrada or going into Cladribine. And again, I always tend to discuss pros and cons of each medication with the patients. So, so the patient had also a matter of preference for that medication, but mainly because there was an aggressive nature, and at the same time, the clinical scenario was not that high to go into Lemtrada again or Cladribine.
Okay. One question from Dr. Talib saying, are you doing MR spectroscopy in some suspected cases of MS?
I don't do it a lot. Definitely, sometimes if we need to differentiate some of those tumefactive MS lesions, if we need to make sure that we are not dealing with tumor, yes, we can go into that. We don't do it routinely, but if there are suspected cases and the differential diagnosis is with metastasis or tumor, yes, we do that.
Okay. A question whether it is a male or female with MS, can they try for to get a baby with Ocrevus?
With Ocrevus, in general, all disease modifying treatment, the preference are to be stopped if the patient is intending to get pregnant. At least I'm speaking about the woman. The man, definitely there is no problem. There were sometimes some concerns about that some of the medication can be secreted with the semen, but usually this is not a major concern. For women, definitely disease modifying treatment should be stopped before pregnancy. Now, if the patient is highly aggressive patient and there is concern of relapses during the pregnancy, some of the medication seem to be safer, such as the beta interferons and the copaxone. Seem to be safer than others.
You know, if patient become pregnant while on treatment, what would you recommend?
Definitely, we recommend to stop the medication on treatment, and the best choice is always to tell the patient about if there is any intention of getting pregnant and all that, because it's better definitely to have the precaution before the pregnancy. But if the pregnancy happened, yes, we stop the medication. Now again, if during the pregnancy, after stopping the medication, the patient had an attack, then we may consider in this case beta interferons, and sometimes we may also consider for the attack itself the Solu-Medrol and IVIG.
Okay. Another question, would you consider switching Ocrevus in signs of disease activity like MRI or relapses, or is it only considered when the patient progress on the EDSS scores?
Do I consider switching to Ocrevus, you mean? Only on a clinical basis, or if there is clinical basis, or only if there is radiological? It's always better to correlate both of them. Now, if you are dealing with a clinically stable patient, no attacks, no progression, but we saw that there is only one lesion, I may not consider to switch. No. Again, if we are dealing again with even two lesions which are very small, without any change in a clinical scenario, frankly, I may not consider. But more than that, yes, sometimes with increased radiological lesions, if you are speaking about 2 or more lesions that are typical of MS lesions, and or they are enhancing and all that, yeah, this is an indication that there is progression going on, and we need to switch to another medication.
Okay. In treating MS patient, which outcome do you usually go after? Is it reduce the burden of the disease? Is it reducing the relapse? Is it decreasing the lesion? Which outcome do you put as a target in the therapy?
Frankly, we should put all of them. Definitely one is more important sometimes than the other, but definitely we need to put all. Clinically, again, the clinical outcome is the most important. For example, to avoid the progression and to avoid relapses. But again, we should also consider radiological as a second target after that.
Okay. Dr. Tawfiq mentioned in his first slides that many patients do not have clinical symptoms, but they have inflammation for a long time before the clinical symptoms actually appear. So do you recommend screening patient, like people screen osteoporosis and other diseases or rheumatoid arthritis? Do you think MS, is there enough MS that warrant screening with MRI for anybody who cannot remember what he ate yesterday?
Definitely not, frankly, for many reasons. First of all, even though multiple sclerosis is a very debilitating disease, but at the same time, it doesn't reach the percentage wise to go and screen all people for that. Second of all, as we know, MRI is a costly test, and it is unwise to go and screen again with MRI for that. So no, I don't recommend that.
So what do you recommend? I mean, if somebody have a family history, I mean, when should patient actually go and consult before they get clinical symptoms?
Okay, now if there is a high familial history, this can be this can be one indication. Now again, we may emphasize that if the patient had any symptoms, that they should not delay the investigation. But if they don't have symptoms and no significant family history, maybe we don't, because still even till now there are some studies going on now that are speaking of possible following radiologically isolated syndromes to see if we treat them with like Tecfidera and Obagio, that will help over the long run. But still, it's not approved yet. And I don't think still in hands, we don't have yet the definite answer to go and treat the radiologically isolated. So I don't think it warrants this kind of investigation.
Is there any lab test? Sometimes, I mean, a patient come and do blood test for different visits, not specifically neurology. From these lab tests in the lab, would they any of the lab trigger an indication to identify patients who might be at high risk of MS?
Frankly, usually not. Usually not. I mean, definitely now, if we are dealing with, we saw, for example, increased, let's say, ESR and CRP, there are multiple diseases that we can think about before we consider MS, because anyway, MS is very rare also to cause any increase in the systemic markers. If we are speaking about, it's very rare. But if we ruled out everything else and maybe with some symptoms, non-specific symptoms, we may consider that. But frankly, usually not.
Mhm. And reimbursement-wise by the insurance company, is there any preference for them to start on the platform therapy versus disease-modifying therapy?
From insurance point of view, now we need to give the right documentation about why we need this treatment, because definitely from insurance companies, they prefer always to go with the platform therapy and with the cheapest. Let's put it this way, with the cheapest medications. So that's why we need to provide them with the right documentation and with the justification why we are choosing this medication over another.
Okay. I don't see any other questions. So I would like to thank you, Dr. Caesar and Dr. Tawfiq, for very informative sessions and very excellent Q&A time. And I'd like to thank Roche for sponsoring this seminar and for bringing to our patient here in UAE a state-of-the-art therapy for MS that help them in resolving their symptoms and reducing the relapses in this difficult MS disease. So we'll see you later, inshallah, in other seminars, and have good night and thank you. And tomorrow by email, you will get the evaluation form to get your certificate for attending this seminar. Have a good night.
Thank you. Good night.
Bye-bye.
Bye-bye.